I would like to thank James Person for giving me this opportunity to talk to you today. I'm medical Dr. Thang from the SA unit. In this presentation, I'm going to tell you about the result of rescue intracranial stenting after failure of mechanical thrombectomy in acute ischemic stroke in S.I.S Hospital. But before telling you about our study, let me walk through some background information. After success of 5 ICT, recommend mechanical thrombectomy was the first line in vessel occlusion in acute ischemic stroke. However, has made a meta-analysis so that mechanical thrombectomy of failure account for 28.9% in patients older than 80 years old. In Asia population, la intracranial arterial stenosis account for 30%. After failure of mechanical thrombectomy, many studies recommend rescue intracranial stenting was alternative to achieve permanent recanalization. Therefore, the aim of our study was to assess both the non-poor outcome as treatment and the symptomatic intracranial hemorrhage relating to procedure in patient receiving rescue intracranial stenting. In normal branch, there are 130 billion neurons. If treatment fails to occur each hour, the brain loses as many neurons as is in almost 3.6 years of normal aging. To realize the aims, how did we go about investigating this? This study was registered in clinical trial. 85 patients have a rescue intracranial stenting were eligible patients from August 2019 to May 2021. Inclusion 1. Evidence of intracranial vessel occlusion. 2. Absence of intracranial hemorrhage. 3. Severe stenosis or occlusion after mechanical thrombectomy. Exclusion 1. Tandem lesion. 2. Loss to follow-up after discharge. 3. A severe or fatal combined illness before acute ischemic stroke. To define the variable, recanalization failure were defined MTC or less 2B. Non-poor outcome include as good and fair. On patients were used 300 mg clopidogrel and 162 mg aspirin via nasogastric tube. Symptomatic intracranial hemorrhage include intracranial hemorrhage plus post-procedure dural MRS greater than 5 and no evident increased MRS. MRS treatment were investigated by phone interview. This was the follow-up of our study. We recorded 67 occlusion and only 46 mechanical thrombectomy. And our result recorded for post-procedural symptomatic intracranial hemorrhage. Now, let me turn to the interesting result and show you the importance of our study. MRI Tesla allow us to diagnose occlusive lesion about 4 times as many as the false positive ratio with sensitivity 98.5%. Thanks to SWI, we could say the total procedure time to differentiate lesion as omission between intracranial stenosis alone and thrombus together with one, such as repairing and setting up interventional device at the outset of procedure, which could decrease the number of cases with total procedures time more than 60 minutes. This is the example. We see the clot in SWI. In the angiography, occlusive MCA after thrombectomy, and it saves the time for successful recanalization. This is the map of this WI aspect and PC aspect for posterior circulation. This is the effect of this WI aspect on outcome. Our study was record a point for the threshold to relate poor outcome treatment. Effect of BC aspect on outcome threshold was 6 points. If BC aspect less 6 points, it's related poor outcome treatment, and with sensitivities 100%. This was distribution of stenosis level from the 80.8% was occlusion to 96.5% mild stenosis after rescue intracranial stenting. This was distribution of MRS. MRS treatment account for with a non-poor outcome 55.3%, and 18.8% was death. This was the risk factor to relate poor outcome with the different were significant. Smoking was a remarkable risk factor, and the compressive craniectomy and unrehabilitation was related poor outcome with N and H relate respectively 2 and 3. This were the related risk related mortality. Our study will record a patient was used RTPA for really good outcome and 3 poor outcome, and no complication, no symptomatic intracranial hemorrhage, and not really poor outcome treatment. This is a complication with procedure. 3 patient new infarct, 4 patient symptomatic intracranial hemorrhage, and 1 metabolic acidosis. This is the spectral slide because that's related complication. That was NNT. NNT was 2. If patient were used that before the rescue intracranial stenting, it would decrease 2 cases with new infarct, 2 cases symptomatic intracranial hemorrhage, and 2 cases metabolic acidosis. That lower rate of any stroke and ischemic stroke. In patient with ischemic stroke or TIA was used that immediately, and short course were effective and safe than monotherapy. In the European stroke organization guidelines were recommend that were used within 24 hours at least 150 milligram aspirin and 300 milligram clopidogrel. We recognize anterior circulation and posterior circulation. Anterior circulation was favorable than the posterior one, and only if a severe symptom of ischemic or posterior lesion, example under-consciousness, dysphagia, and ataxia, were ischemic, were patient hospitalized to be recanalized because their initial symptom, headache, vomiting, dizziness, could be presented early and mildly, but they be less obvious than one anterior circulation. And posterior circulation relate with poor outcome treatment, and the difference was significantly. They two study was recognized, group non-stenting and group rescue stenting, and the different significant in the good outcome and mortality. Compare good outcome and mortality of anterior circulation. Our study was favorable than Perret and Chang study, and the different were not significant. This is the study only without rescue stenting, and the mortality of mechanical thrombectomy account for 26%. Compare symptomatic intracranial hemorrhage of anterior circulation. Our study were favorable. The other study. Comparison the symptomatic intracranial hemorrhage with struggle between anterior and posterior, and our study were favorable, but the difference was not significant. This is case report. Man 67 years old, stupor onset 7 hours. Man patient with stupor, global aphasia, hemiparesis left 0.5, facial paralysis, MRS 5, needs 23 point. Angiography recognized occlusive MCA. After thrombectomy, it was severe stenosis. After rescue intracranial stent, MTC 3. Post procedure in CT scan were not recognized hemorrhage. MRS discharge 2 point, MRS treatment 1 point. I think that the result presented so far can allow me to make the following point. First, time is friend. 2, that were used immediately and short course. 3, anterior was more favorable, posterior in good outcome. 4, MRI treat Tesla was useful and save time for treat patient with acute ischemic stroke. Rescue intracranial stenting was alternative treatment to achieve permanent recanalization. Finally, rehabilitation was important to help patient return independent. I would like to conclude my presentation by expressing my appreciation to the following college in this slide. Thank you again for your attention, and I'm happy to take your question.